This is a reading from Dr. Kathryn Mannix's new book called Listen, and the chapter is called Anger. Anger is about unmet expectations. It is an alarm response generated by a gap between what is happening and what someone believes should be happening. A perceived lack of fairness, a breaking of the rules, whether explicit or unspoken. Discussion while one or both parties is feeling angry can make the conversation difficult, and anger can turn a conversation into a confrontation. How can we best navigate discussions when anger is also present? I'm sitting in an oak-paneled room high above the gardens of the Victorian part of our hospital. The windows are open to the cool air. It's high spring, and a bee buzzes heavily through the room and exits via another window towards the top branches of a heavy-scented magnolia tree beyond. Sitting with me are the complaints manager, Enid, and a retired eminent professor of surgery, and we are preparing to meet the unhappy family of a patient who has died in the care of our hospital. We are spaced out around a long polished conference table. There's a water jug and a collection of glasses on the table, a box of tissues, and a tape recorder with a gray microphone. There is an atmosphere of quiet contemplation, the calm before the storm. Professor Price was a senior surgeon in this organization for many years. He taught me as a medical student. I found him terrifying. Since retirement, he has taken on a conflict resolution role, and it has been an education for me, as the hospital's end-of-life care lead, to see him in action. The fiery young surgeon I used to fear has been transformed by his life experiences into a wise elder. It is not his glittering career, but the challenges, bereavements, and personal losses he has weathered that have turned his passion to patience. His once famous temper has been reduced to a spark that ignites at injustice. When he talks to people making a complaint about care, his palpable sense of their right to fairness sets them at their ease. He can sit with other people's anger and acknowledge their right to feel it. Equally, he brooks no unjustified criticism of the intentions of staff to deliver an excellent service. His is a court of polite listening, generous empathy, and clear rules of fairness. Enid has provided us with bundles of paper, copies of case notes, nursing notes, drug charts, letters from the family, responses from the hospital's senior team. It is all depressingly familiar. An elderly man, beloved of his family, was admitted to hospital for something that seemed routine. In hospital, it became clear that he was very much sicker than anyone had previously realized. His surgical procedure went smoothly, but his background health deteriorated and he died before he could get home. His family perceives that since he was not too bad when he came into the hospital, his subsequent deterioration and death must be someone's fault, and that the hospital is failing to tell the truth. Furthermore, on the night before he died, the patient became muddled and called home to say the staff were threatening to kill him. Understandably, his bereaved family was shocked, perplexed, and angry. An extensive investigation at the hospital has identified the reasons for his downward trajectory. It has established that he tried to spare his family concern by not disclosing bad news to them. But once his already failing kidneys finally stopped working altogether, he experienced confusion caused by an accumulation of toxins in his blood. In his confusion, he sensed imminent death, forgot he had forbidden staff to tell his family any bad news, and called home to plead for help. What a frightening time he must have experienced, alone in hospital, with a sense of unexplained, impending doom. What a shocking phone call that must have been for his wife, who came by taxi within minutes of his calling her. How difficult it must have been for his family to make sense of how close this man was to death when they had no idea how sick he had become. No wonder they blamed the hospital for his death. I am also aware that their anger is distorting and complicating their bereavement. Unable to resolve the pattern of events of their beloved's hospital stay, they are trapped in a grief twisted by their belief that his death was avoidable and was caused by a failure of diligence and care at the hospital. This is like a weeping wound, and no healing can begin until the cause of their anger has been resolved, if that is possible. In preparation for this meeting, I have read and reread all this information, mapping the story out on a piece of paper. Mr. Rook was in his 80s, a retired butcher. I know his shop, now run by his son. Mr. Rook was known to have breathing problems and arthritis that limited his walking. Enlargement of his prostate gland, not uncommon in older men, had begun to obstruct his bladder, and, unwilling to tolerate a catheter, he had come into hospital to have a simple procedure under anesthetic to remove part of his prostate and allow urine to flow again. At the hospital, routine blood tests showed kidney damage from the urine blockage was already significant. Mr. Rook forbade the team to tell his family. The anesthetist for his surgery was worried about Mr. Rook's combination of lung problems, aging heart, and kidney damage. There is a note about her conversation with him. The anesthetist warned him about the small possibility of complications of having prostate surgery: heart attack, bleeding from his bladder, breathing difficulties, infection. She notes that he accepts those risks and does not want to worry his family about them. It is clear from the notes that Mr. Rook came through his surgery reasonably well, although blood tests showed that his kidneys had deteriorated further, making him sleepy the day after his operation. Mrs. Rook came in to visit him that afternoon and assumed his sleepiness was caused by the drugs needed for his surgery. She told the nurses her husband had never wanted a catheter, and they explained that a catheter had become necessary to help them monitor Mr. Rook's poor kidney function. The nurses were concerned that Mrs. Rook did not seem to understand the implications of the poor urine output and suggested that Mr. Rook's kidneys were not recovering. All these conversations are recorded in his notes. The following day, Mr. Rook was even more sleepy, a bit short of breath, and slightly muddled. His blood tests showed that his kidneys were getting worse. At visiting time, the nursing notes record that Mrs. Rook was upset to see her husband so sleepy. Mr. Rook has forbidden giving medical information to his family. The charge nurse explained that Mr. Rook's kidneys have been damaged by the back pressure from his prostate, and this can take time to recover. That night, Mr. Rook became restless and agitated, and he pulled out his catheter. He used his mobile phone to call his wife at 3 o'clock in the morning and told her that the hospital staff were trying to kill him. The family came in quickly, and Dr. Shaw, the gentle Iranian junior doctor, explained that the kidney failure was causing Mr. Rook to be confused and sleepy. She told them that Mr. Rook was becoming increasingly unwell and that it was possible he was so sick now that he could die. The family protested that Mr. Rook had never had anything wrong with his kidneys, he only had prostate trouble. They accused Dr. Shaw of telling lies, of covering something up. They demanded to see a more senior doctor. The next day, with his family around him in a state of distressed disbelief, Mr. Rook continued to deteriorate. He was too frail for hemodialysis. His kidneys had stopped working completely. He died that evening, his wife at his bedside, as she had been since the agitated conversation with Dr. Shaw. A bang as the heavy door of the room slams in the breeze from the open windows announces the arrival of the surgeon who was looking after Mr. Rook. He is dressed in suit and tie rather than the scrubs I usually see him in. He is carrying his bundle of papers provided by Enid, and he looks anxious. "They have said some very harsh things," he comments, placing his papers on the table and pouring himself a glass of water. "My trainees are very distressed. Poor Dr. Shaw is distraught. She has never had a complaint against her before." He sits down and looks at the prof. "Okay, boss?" he asks, and I realize that Prof. Price must have trained Max in the early part of his career. "Relax, Max," said Prof. "Your juniors have nothing to fear, but you'll hear me ask the family their full story, and they may say critical things. The important thing is not to interrupt. They need to feel heard. No matter who else is sad or anxious today, the fact is that they are bereaved. The investigation doesn't seem to indicate that anyone is at fault, but he died in our care, and their anger is a part of their grief. So, Max," Prof looks at him sternly, "I'll give you a chance to speak, but I need you not to get cross. Do you get me?" Max smiles and his shoulders relax. Good trainers have an almost parental defensiveness toward their trainees. Prof has had that relationship with Max. Max has it now with Dr. Shaw. Feathers have been ruffled. Max wants to defend his protege. Prof's words are important. It's difficult to find our compassion if we feel angry or defensive. Prof is holding the room in balance. Today, our hospital's representatives must be centered on our compassion for his family. We want to help them to understand what happened to their beloved relative. If there have been faults or mistakes on our part, we must own them with humility and sorrow. We may need to give the family explanations, but we are not here to defend. We are here to listen. Max recaps the story we have all read. He answers our questions so that all the details are clear to us. Max and I work together regularly to keep his collection of elderly men with prostate cancer comfortable, mobile, and symptom-free. He is young, an enthusiastic surgeon, and tender as a son with these old men. Like Prof of old, he is passionate. A fervor that can be fanned into anger when operating lists run late or standards of care are not what he demands. The clock in the hallway outside chimes the half hour. It is the Rook family's appointment time, and Enid quietly opens the big door to bring them inside. Mrs. Rook is short and pale. She walks cautiously with a stick. Beside her are two men of about my age, her sons. I recognize one from the butcher's shop. They are welcomed by Prof, and we all sit down. Prof asks the family's permission to record the session. They agree, and Prof presses the record button. He always does this with a slightly theatrical flourish. I drop my eyes to my lap. Any sign of amusement would be misplaced in this tense gathering. "I think you know Mr. Max Evans, one of our consultant surgeons, and the doctor responsible for Mr. Rook's care in our hospital," Prof begins. Mrs. Rook snorts, and her sons nod at Max. Max says, "I'm glad to see you again," and Mrs. Rook mutters, "I'm not a fool." I sense this will be a difficult meeting. "You won't know Dr. Kathryn Mannix, who is our end-of-life lead," says Prof. "She has been looking through our investigation report to see whether there is anything we can learn from what happened. And I am Professor Eric Price. I was a surgeon in this hospital, And now I am the chief executive's representative at family meetings like this one. You are very welcome here. I know the circumstances are very sad for you all, and I appreciate you giving us your time today. Enid is taking notes. She will give everybody here a copy of the notes she makes. The tape recording is solely to help her to complete her notes. Is that acceptable to you all? There is general nodding and murmuring. I wonder why Enid is not accorded a surname or a job title, and I feel a spark of sisterhood being frequently introduced differently from my male medical colleagues. All alike in dignity, I misquote in my head. Now, would you like to introduce yourselves? Asks Prof. The son I recognize speaks. I'm George Rook, son of Robert Rook, who was your patient, he says. This is my brother Paul, and he's a pharmacist. He's been giving us medical information while we have been trying to make sense of all this. And this is our mom, Robert's wife. Mrs. Rook, George, Paul, I'd like to start by saying how very sorry we are that your husband and your father died in our care, says Prof. I know this is a very difficult time for you all, and we all offer you our sincere condolences. I offer condolences too on behalf of our chief executive, who has asked me to report back personally on the investigation of Mr. Rook's death. The Rook family made no response. There is a silence. The Rook family make no response. There is silence. I'd like to start by inviting you to tell us what is causing you the most concern. We have all read your letter of complaint and also your letter responding to our investigation of your complaint. But today let's talk and listen to each other to try and answer your questions and see whether there were things we could have done differently. I notice his use of could rather than should, or whether there were things that were outright mistakes. Mrs. Rook looks across me at Max. Your staff failed my husband, she states. He was a well man when he arrived for his op, and a few days later he was dead. That should not have happened. Something went wrong, and we want to know what it was. Max holds her gaze, and I sit back like a tennis umpire caught between them. Prof speaks. You feel something went wrong, he says, and you believe that we are hiding something? Without a doubt, says Mrs. Rook. He was well, then he was dead, and you, she turns to Max, operated on him in the gap between. So what went wrong? What mistake did you make? Her face quivers. He should be alive now. You should be in prison. There is a pause. Prof comments gravely. Mrs. Rook, we know you are deeply distressed by the loss of your husband. These are strong emotions. But I must ask you to bear with us patiently today and try to not shout accusations. We will listen to you carefully, I promise. There will be no need to shout. Is there anything else you would like to tell us or to ask us about what happened to Mr. Rook? About his care or about the treatment or his surgery? All I know is he is dead, and a fit man should not have died. I want to know everything, and I want to know it now, says Mrs. Rook, her voice quivering with her head. In that case, I'd like to ask Dr. Mannix to talk us through her understanding of events. Prof continues. She was not involved in his care, so all her remarks are made as a neutral party. Mrs. Rook snorts again, saying, You're all as thick as thieves. I take a deep breath, conscious of her quietly determined rage for justice simmering beside me before I begin my summary. The case notes are in front of me, but instead of using them as a shield, I turn in my seat to face her. I tell her I have gathered the story from reading the clinic letters, the blood test results, ward notes, and lab reports, and I'd like her to check that I have understood the details. I start before Mr. Rook had ever been seen by Max's team. I can see that the prostate problem Mr. Rook had was a real nuisance for him. He was struggling to pass urine, and he complained that he needed to get up several times during the night. Have I understood that right, Mrs. Rook? She nods her quivering head. I can also see that he had arthritis in his hips and knees, so getting out of bed would have been painful, as well as a nuisance in disturbing his sleep. Even when he got back into bed, I suspect it would take a while for him to get comfortable enough to fall asleep again. Is that a fair comment? She nods again and says, he complained about his bad nights, but he was always a coper, Bob. He wanted to look after me, not the other way around. I tell her that Mr. Rook's wish to look after her is clear from the notes. He had mentioned it to several people. She looks at me in the eye for the first time. Can I move on to talk about the operation? I ask. She nods. I can see that the surgery was planned for 2 reasons, I say. First, he didn't want to use a catheter, even though that would have easily solved the practical problem of struggling to pass urine and disturbed sleep. He told Mr. Evans that he would rather be dead than have a catheter. That's a pretty clear message. Did he ever discuss it with you? She shakes her head. One of her sons says, we didn't know he'd been offered a catheter. We wondered why not. In the referral letter from his GP, the doctor comments that he is set against using a catheter, I reply. So both his GP and Mr. Evans spoke to him about it, and for his own very important reasons, he turned it down. The doctors respected his choice. I paused to let them take in that fact. The other reason surgery was planned was that Mr. Rook's prostate had got so big it was blocking the flow of his urine, and that was causing back pressure on his kidneys. He had blood tests and x-rays ordered by his GP. Do you remember that? I turned to Mrs. Rook. Well, he told me there was a bit of a holdup in his urine, she says. He didn't tell me his kidneys were damaged. I don't think he knew that. The doctor should have told him. Why wasn't he told? The GP letter to refer him for surgery says, I explained that his kidneys are showing signs of damage, and unless the obstruction is relieved soon, his kidneys will fail altogether, but he still refuses to consider a catheter. It seems that his GP told him, Mrs. Rook. She gazes at me, and I cannot read her unblinking expression. I tell the family that the clinic notes and letters written by Max's team after assessing Mr. Rook in their clinic emphasize that the operation was a matter of urgency. The urgency was to save his kidneys. That's why he was admitted so soon after his clinic assessment. Does that make sense to you all? Paul Rook, the pharmacist, clears his throat. May I say something? Of course, says Prof. Dad was a very private man, says Paul. He never liked to fuss about things. His aim in life was to run his business well so that we could have a good life. After he retired, he wanted Mum to be happy. He felt he had neglected us when he was busy with the shop, with all the paperwork, the accounts and ordering and early morning starts. He wanted to make up for all that. Mum was his world. Through the corner of my eye, I could see Mrs. Rook's hands beginning to shake. So it's not unlikely that if he had medical problems, he would have kept them to himself. Dad was like that. Thanks for telling us that, I say. He sounds like a very kind and determined person. If he was keeping secrets, it was out of love for you all. I want to be certain that there is no sense that we are blaming Mr. Rook for the effects of his secrecy. Rather, it was intended as an act of kindness and protection on his part. Can I take us all through what happened from the day Mr. Rook came into the hospital? I asked, focusing again on Mrs. Rook. I can hear that you have concerns that things happened that you didn't know about, and I think that's true. But it isn't because anyone was covering up. It's because Mr. Rook asked the staff not to give medical information to his family. He didn't want to worry you. Let me take it day by day. So instead of telling us the truth, you told us lies? Interrupted Mrs. Rook. He was gibbering. He didn't know what he was saying. But you followed his crazy instructions? I am his wife. I had a right to know. The gap between what we expect, what should have been, and what happens is what triggers anger. Anger uses the language of should, what the world should be like, how people should behave, what I should have been entitled to expect. Mrs. Rook expected her husband to have a simple, short trip to the hospital. She expected him to be giving her all the information he knew. She expected that if there were medical concerns, she would be informed. These are her shoulds. Yet the law is clear. Every patient has a right to confidentiality, and our contract is with our patient. People can make unwise choices. We may try to dissuade them, but in the end, it is their right. Declining a catheter was an unwise choice. A few weeks using a catheter could have allowed Mr. Rook's kidneys to recover and make surgery safer for him. Their letters show that both his GP and Mr. Evans's team discussed this with their patient. Declining the catheter in the face of deteriorating kidney function was the first step in a chain of events that led to his death. Mr. Rook made decisions that he kept from his family. In retrospect, that was another unwise choice. I keep all this in my head. I need to choose my words carefully. I can see from the notes that he intended to protect you from worry, I tell Mrs. Rook. He didn't see it as lying. He saw it as kindness. It sounds as though that fits with what Paul is telling us about his character, too. What do you think about that? Her hands clench on her lap. The table is high, and she is slightly stooped, so the top of the table is at chest height for her. It's disempowering, and I don't know how to remedy it. The way we arrange our furniture changes the dynamics of a conversation. We need a low, circular table that has no head seat for these meetings. We need comfortable chairs. We need beverages. This Victorian marvel is imposing, but it says that the hospital is in charge. This room is not on the visitor's side. They should have told me, she says, but this time it was a sigh. They wished they could tell you, I say, feeling the weight of her bewildered sorrow. And in the end, Dr. Shaw did tell you, didn't she? But what a shock it must have been by then. You had no idea how sick he already was when he arrived at the hospital, did you? Mrs. Rook shakes her head sadly. Then she lifts her chin resolutely to speak again as another wave of anger buoys her. So did the shock of the operation make things worse? Was it a mistake to operate? The only way to protect his kidneys was to operate, I say. There was not really a choice. The alternative was kidney failure, and his circulation wasn't strong enough for kidney failure treatments. I look at Max. Mr. Evans knew it was a risk, and he has written in the notes about discussing the risk with Mr. Rook. Do you want to say more about that, Mr. Evans? Max leans forward to look past me at Mrs. Rook. It was all about looking after you, Mrs. Rook, he says. I need to be well to look after my wife, your husband told me. He said you'd been diagnosed with Parkinson's disease, and he needed to be sprightly to look after you. Mrs. Rook holds Max's gaze, her wobbly head demonstrating her Parkinson's. I didn't know he had forbidden the ward team to give you updates, continues Max. I always think it's best for families if there are no sudden surprises or shocks. If I'd known he'd forbidden them to update you, I would have tried to persuade him. Max pauses before adding, I'm so sorry. That was very tough for you. This is the tenderness I have seen in him at bedsides. He means it. There is another silence before I pick up the story. The surgery went smoothly, but Mr. Rook's kidneys didn't recover as hoped. Fluid was accumulating in his body, settling on his lungs. Paul leans forward. I want to ask about that, he says. His kidneys were already failing. Then someone gave Dad a slug of furosemide. That seems to have knackered his kidneys completely. Whose decision was it to give furosemide, and what do we think about that decision now? This has been an important piece of the internal inquiry, and I say so. The drug is signed for by Dr. Shaw, who is a junior surgery trainee, I reply. In the notes, she records asking advice from a consultant in the renal team. I look at Mrs. Rook. That's a kidney specialist, the best person to get that kind of advice from. The renal team consulted, reviewed Mr. Rook's blood tests and chest x-ray, and advised that, despite the risk of further kidney damage from the furosemide, the presence of pulmonary edema, water in his lungs, Mrs. Rook, was more life-threatening at that time. So it was a calculated risk, a medical judgment, all recorded in his notes. So it was a calculated risk, a medical judgment, all recorded in his notes. In my mind, I give thanks for Dr. Shaw's exemplary note-keeping. It's not always so easy to glean the details of medical decisions. Paul sits back. Makes sense, he says to his family. No drug is without a risk. I think I'd have given the same advice in those circumstances. Hobson's choice. After that, Mr. Rook's kidneys just kept deteriorating, and kidney failure makes people muddled, I say. The muddle explains why he phoned you, Mrs. Rook. He was frightened because he felt so unwell, and you were always his biggest comfort. I pause. I ask whether Mr. Rook was awake when she arrived. She looks at George. Yes, I was there in 20 minutes, and George was there soon after. He knew it was me, and we were able to sit together while the nurses tucked him back into bed. I couldn't believe the state of him, so muddled and blood on his pajamas where he'd pulled that catheter out. She shudders. And then that young doctor with the headscarf came in to talk to us. She told us he was very sick and that he might die. I couldn't believe it. I shouted at her. I made her cry. And what do you think about that conversation with Dr. Shaw now? I ask. Mrs. Rook looks at her sons, then down at her clasped hands. She sighs. She was the first person who told me the truth, wasn't she? Says Mrs. Rook. I had no idea he could get so sick. But knowing he could die made me stay at the hospital. I'm glad she told us. I'm glad I was there. I was so angry with her, but I think she did the right thing. I'm sorry I made her cry. She was doing her best. She was kind. She wasn't being a bad person. Do you think anyone was a bad person, Mrs. Rook? I ask. She bends her trembling neck, and I see tears drip into her hands. She takes a long time to answer. Eventually, in a voice that is tired and sad, she says, No, everyone did what they hoped was best, even Bob, keeping secrets from me. How could he? And she begins to weep. Max pushes the box of tissues down the table towards her. She nods to him as she takes a tissue. Then she sits, twisting it in her fingers. Prof waits, and the silence lengthens. Finally, he says, If you feel your concerns have been properly attended to, I will draw our meeting to a close. Does anyone have anything else to add? He waits, and no one speaks. Do you have any concerns that we have not addressed today? He asks the family directly. Mrs. Rook shakes her head, mops her eyes, and Paul says, It's been thorough and professional, Professor Price, thank you. It's helped me, And I hope it's helped Mum and my brother too. George nods. Mrs. Rook twists her tissue in her trembling hands. After they have departed and Max has expressed relief that the meeting seemed to lift their misapprehensions about covert foul play, Max and Enid leave to pick up their next duties. Alone with the prof, I have one more item to discuss. I am still in awe of him. I have a criticism to offer, and I feel anxious about how he will respond. But just as anger can erupt into conflict and rage, sometimes it provides the energy that sustains people through despair, or it is the spark that ignites a quest for justice. Anger isn't bad. We simply need to use it wisely. My anger is about Enid's surname. Why were we three doctors given titles and full names, and yet Enid, who has spent hours preparing papers, liaising with staff, and getting ready for this meeting, was simply Enid when introduced? At medical conferences, I observe senior doctors introducing each other with titles for men, but first names for women of equal or even superior qualifications and experience. This is a lack of fairness. There is a gap between how things are and how I think things should be. And that should is the trigger to anger. I must use my anger well. Taking a deep breath, I commit. Prof, may I ask you something? Of course, Kathryn, he replies. It's about introductions, I say. I'm in now. I have passed the threshold. He looks quizzical. I like the way you introduce everybody in the room to the visitors, I continue, heart hammering in my chest. I particularly appreciate that you gave us all our professional titles. That doesn't happen everywhere, and it's important that visitors know their complaint is being taken seriously by senior people. I'm usually very informal. I know you don't really approve that my patients call me by my first name, but it feels comfortable for us all that way. I'm drifting. I'm avoiding. Say it. I noticed, though, that Enid didn't get a title or a surname. I wondered what she makes of that. She's such an important part of the preparation. She isn't just the note taker. She's a colleague with a surname and a job title, and she might like to be acknowledged in that way. I can tell I'm blushing, which is an infuriating giveaway of my emotions. But I am calling out an injustice, and it is the right thing to do. Anger can feel like a hurricane, a force that overtakes us and leaves us too furious to choose our words or to weigh the consequences of our actions. But it can also be a force that propels us for good. I'm learning to be brave. Courage is a sail that catches the wind of anger, using it to set a course for justice. Prof pauses in the gathering of his papers. He looks at me, and then away, thoughtfully. I'd never even thought about it, he admits. I don't think I noticed I was doing it. But I'll try to do better, Dr. Mannix, he smiles. Thank you for saying so. I will do better. Do you have time for coffee before we get back to work? And holding the door with delightful courtesy for me to leave the room ahead of him, he accepts the feedback. I am humbled by his quiet grace. This is Rae Weniger, the narrator of this chapter from the book by Dr. Kathryn Mannix of the UK called Listen, How to Find the Words for Tender Conversations. The title of the chapter is Anger, and I've recorded this so that a friend of mine who is struggling with anger at this time can have a listen to just this chapter. Of course, this book is available from the United Kingdom at this time in book form and as an audiobook that was read by the author herself, which, if you have enjoyed this reading, I hope you rush out and purchase. You would have to buy it at this point through Amazon.uk. There isn't at this time a Canadian publisher, and I think there soon will be. because this has gone to the bestseller lists now in England, and it's a marvelous, important read. Thanks for listening.